All right, well, welcome everybody. And we're very pleased to present MedStar Emergency Physicians pop-up learning session. And this is our second learning session in the series dealing with COVID-19 and our response to it. We're very pleased to have Dr. Rory Spiegel, who is our Director of Critical Care Education and Research and is an emergency physician at MedStar Washington Hospital Center and also an attending in the SICU at the hospital center as well. And so any questions that come up during the course of the presentation, please feel free to email them to me, jonathan.davis@medstar.net, and we'll incorporate them into the conversation. And we'll also hold some for the end as well, but we'll make sure that we cover all of your questions. So without further ado, Dr. Spiegel, thanks so much for joining us.
Yeah, thanks for having me again. Hopefully this is productive. So, we are all getting prepared to deal with the surge of COVID patients that we're seeing around the world and around the country. And the limited data we have coming out of China and out of Italy shows that there are mostly what you're seeing as they get into trouble is an ARDS pattern. And we don't have great data specific to COVID patients, but we have a lot of data on managing ARDS and the kind of ideal ways of treating those patients. So I thought, knowing that as this surge gets farther in, more and more of these patients are going to be boarding the ED for longer and longer periods of time. We could kind of go through kind of a simplified approach to ARDS, what it actually is, how we should think about it, and then just kind of simple tips on how to manage it during the first few hours. Hopefully not more than that, but we'll see. So essentially what we're talking about specifically here is a viral pneumonitis that's causing diffuse lung injury pattern. So this is a pretty severe version of it, as you see diffuse airway edema throughout all the lungs. And what we have now is the Berlin definition of ARDS, which looks something like this. So you have bilateral opacities on a chest x-ray. It's non-cardiac in origin, so this isn't cardiogenic pulmonary edema. Decreased P to F ratio, so the partial pressure of oxygen over the FiO2 content that was required to get that partial pressure of oxygen. And they break it down into mild, moderate, severe, mild being less than 300, moderate being less than 200, severe being less than 100. And I always find that when you have these like checklist definitions, you lose a sense of what we're actually trying to get at here. And if you listen to the people that created this definition, they all met in Berlin, hence it's the Berlin definition, and they spent a week about arguing over what the definition of ARDS was, and they couldn't really come up to a conclusion. And like about an hour before they had to leave and get on their flights, they just kind of threw something together. And what they're trying to get at is this. This is ARDS, right? It's a pattern of lung injury where you can see you've got bilateral opacities that are more prominent in the lower posterior regions of the lung, and as you get more and more to the front, you have more and more normal lung. And so the idea here is that you don't have stiff lung that we generally think about it is, you have baby lung, and because of the injury or the edema in the lung, the most dependent areas kind of get swished and soggy and de-recruit and collapse, and so you have a smaller area of lung to work with. The other important note, it is a syndrome, right? Like lots and lots of things cause ARDS, because ARDS is just a result of extra fluid in the lungs and leaky capillaries. So pulmonary edema from cardiogenic pulmonary edema is technically similar to ARDS, right? You've got leaky lungs because your heart isn't working right and you have excess fluid. The reason we want to exclude it is because that responds really, really well to diuretics and just extra PEEP. And so it responds a little different than almost all the other things we're talking about when we're talking about ARDS. But the important note is it's a syndrome. And the syndrome, what we're trying to describe, is something like this. The reason we use mild, moderate, and severe, and they use the P to F ratio, is they're trying to get at the point that you have different degrees of atelectasis or de-recruited lung. And as you have more and more de-recruited lung that's not participating in ventilation, you have a greater and greater shunt fraction, which means more blood is going from the right side of the heart, deoxygenated, coming to the lungs, not getting reoxygenated, and passing to the left side of your heart. Right? And so you need a higher and higher oxygen content to get the same oxygen saturation or get the same partial pressure of oxygen. So the idea is the worsening that shunt fraction or the worsening the P to F ratio, the more of your lung is going to be de-recruited. And that's kind of the concept of the Berlin definition. And the most important thing I want you to think about when thinking about ARDS is this shunt fraction, or the degree of lung that's derecruited and not participating in an ARDS, because that's the most important thing in thinking about the management of them. And so this is the concept of the baby lung. And the thought here is really important. You have normal lung. So it's not stiff lung. It's the compliance of the lung that's participating in ventilation is completely normal, just like the CT and the anterior regions. It's just small because so much of the lung is no longer recruited and being ventilated. And so you want to think about the lung as a baby lung or a smaller than normal lung. And that's why this concept of lung protective ventilation came around. The whole idea of low tidal volume ventilation, or 6 cc's per kg approximately, was out of this concept that if we give someone a normal tidal volume, or the standard volume for their regular lung, it'll be too high for this baby lung, and you're going to cause more injury for over distending the lung that they have. So giving them an appropriate size tidal volume for the lung that they have now that they're ARDS is really important. And this is where we found that mortality benefit that everyone cites when they talk about low tidal volume ventilation. It was about a 9% decrease in absolute mortality when you ventilated people with a tidal volume appropriate for their lung size. So it's essentially this. If you give someone a tidal volume that's too big for their lung, you start distending the lung and you start causing more damage and more injury. And so the typical recommendation is 6 cc's per kg. And this is ideal body weight. So this is not, some people are a lot larger than their ideal body weight. And if you look at their CT scans, they have normal sized lungs or small lungs in this big person. And what's typically recommended is that you measure the person's height, and you use a height to calculate their ideal body weight, and then you use that to actually get your tidal volume. I always found that's a little bit difficult to do at the bedside in the emergency department. I mean, even finding a tape measure, and then with COVID, you're going to find a tape measure that you can bring from person to person. Honestly, what I typically do is if they're a small man or a woman, I start with 400. If it's a large man, I start with 450. There's reasonably good data that 6 cc's per kg, the exact number, does not predict the size of the lung on the CT scan. So it's a starting point. But since it doesn't predict, I tend to estimate, and then I check my work, and we'll talk about what that work is later. So starting at 400 or 450 on a man or a woman will mostly get you where you want to be. And so that's where I tend to start. So now we're going to talk about PEEP. And the way I want you to think about PEEP is, again, what we're trying to do with PEEP is to maintain the size of that baby lung. We don't want to further de-recruit. The more lung that de-recruits, or the smaller your baby lung gets, the more stress on every individual alveoli and the more damage you have to the lung. So by using PEEP, you're trying to enable, one, maybe you can pop up or a couple more units, getting the size of the lung actually bigger. So what you see here, this is dense ARDS, right? Most of the lung is de-recruited, not involved in ventilation. And as you add PEEP, you start to re-recruit the lung, right? And so you have more lung that's now participating. The size of the baby lung is bigger. And so the patient has less stress on the lung for any given tidal volume you give. There are lots of ways to try to calculate your PEEP. And the good thing about it is no way has been shown to be superior than any other to how to titrate PEEP. So I would say we should use the simplest way, which is essentially a PEEP ladder. So this is what was come up with by the ARMA people when they did the first ARDSnet trial, is this idea that for increasing FiO2 requirements, you're going to increase your PEEP. And what this means, or what the concept is as we looked at earlier, when you see a lung that's requiring, or you see a patient that's requiring a lot of FiO2 to maintain oxygen saturations, that means there's a lot of shunt physiology going on, or there's a lot of lung that's de-recruited, or the size of the baby lung is small. And the thought is it's in those patients that have the most de-recruited lung that would benefit from re-recruitment, or they're the ones that have the most potential to re-recruit. And so you're using the oxygen requirements you need to titrate your PEEP. Because if someone needs more oxygen to maintain a oxygen saturation, then they probably have more de-recruited lung, and so they would benefit from more PEEP. So you can see here are various tables of the degree of FiO2, so 30%, 40%, going up, and the amount of PEEP you would apply to that. I think this is the easiest way to apply this table. And I use this higher PEEP table here that you can see on the bottom here, going all the way up. Just to know, both of these tables, and it's slightly confusing if you look at it, The low PEEP table, it's actually one table. They just couldn't spread it across the whole thing. So you can see it starts at this top part here with 30% and 5 of PEEP and comes all the way down to 100% and PEEP of 18 to 24, right? And then you can see the lower PEEP table also ends at 100% FiO2 and a PEEP of 24. You just more aggressively titrate your PEEP as you're going up. From the data we have, there's not much, but from the data we have on COVID, it seems to respond really well to PEEP. And so my thought is I used a higher PEEP table in this case because of that, in the hope that I can pop people up, increasing the amount of the size of the baby lung and decreasing the stress on their lung itself. But I think either one of these tables will be fine. We're putting together a document now where we'll make these simple recommendations in document form, and I'll include the PEEP table there that we can have. I'll pause here to see if there's any questions.
So does anyone have any questions at this point? Excellent. Why don't we keep on rolling, Rory?
Cool. So real simple so far, right? We put the person on the ventilator, and so far all we've done is titrated appropriate tidal volume. And like I said, you can officially measure the person, but mostly I tend to use 400 or 450, depending on if it's a small man or a woman, or a larger man. I'll use 450 for a larger man and 400 for a small man or a woman. And then we'll kind of talk about how we check our work after that. All right, so checking your work. So basically what we've done so far is we're trying to increase the size of our baby lung, and then we are trying to make sure that we deliver an appropriate tidal volume for the size of the lung of that patient. And so what you want to do, like I said, if these empiric numbers are nowhere near perfect, so you want to make sure that the volume you're giving the patient is appropriate for the size of lung they have. And this is the concept of the plateau pressure. So if plateau pressure is essentially, I put my tidal volume in and then I hold. So I don't let the patient exhale. I just keep that pressure in the lung. And all the vent is doing is now checking the pressure, pushing back against it, now that you have all this air filling the lung. And so you can get really confused with this, but all I want you to think about is the plateau pressure is a surrogate for you to say, is this tidal volume appropriate for the size of lung they have? Anytime you check a plateau pressure, that's what you're asking. Is the tidal volume I'm giving appropriate for the individual size of lung of that patient, right? And so that's what you're asking. And we say plateau pressure should be less than 30. And so what that means is I've given what I think is the approximate tidal volume for this patient, calculating 6 cc's per kg, or doing my simplified approach. I've then applied what I think is the right PEEP, in the hopes that I'll pop open some lung units and then increase the size of my baby lung, so make that tidal volume even more appropriate. And then I'm going to check my work. I'm going to measure a plateau pressure. And the way you do this is every vent has an inspiratory hold on it. You do an inspiratory hold, you hold it for about 3 to 4 seconds, and you'll see your pressure just kind of level out like it does on this blue part on the screen right here. And then the machine will give you a plateau pressure. Your RT, every RT should know how to do this. Every vent is slightly different. Next time you intubate a patient, just ask your RT how to do a plateau pressure, and they can show you. It's very simple. So if your plateau pressure is less than 30, at this point, you're doing okay. You're likely delivering an appropriate tidal volume for the patient, and your PEEP is likely set appropriately. If it's greater than 30, what that means is the tidal volume you've given, even if it's 6 cc's per kg, is too high for the lung that that patient has. And so what you do is you turn your tidal volume down at that point. So your tidal volume goes down until you can get under 30. Simple enough. So your respiratory rate, I usually start at 18 to 22. Even people with healthy lungs that you put on the ventilator, you increase the dead space because of all the tubing that the ventilator has. But patients with ARDS, as you saw from their x-rays, have a lot of derecruited lungs, so have a lot of dead space. So you usually need a higher respiratory rate. And this is where it gets a little confusing. You're shooting for eucapnia, so you want normal ventilation. If you can get someone to a PCO2 of 40, that's good. But sometimes in really sick ARDS patients, you can't. And so what you want to do is you've set your tidal volume for the size of lung they have, and you've checked your work the way we just talked about, by setting your PEEP on your PEEP table and then setting your plateau and then checking your plateau pressure. Once you've done that, that's fixed. You don't change it. So the only way you can change your PCO2 is by changing your respiratory rate. So I start at 18 to 22, and then I'll check a blood gas. And if my PCO2 is high, I'll increase my respiratory rate to optimize that. With the note that most people recommend that 35 is your highest respiratory rate you can go on these patients. And so you have somewhere between 18 and 35 to get the optimal CO2 you have, with the understanding that in really sick patients, sometimes you can't get an appropriate CO2 and you tolerate a higher CO2, knowing that increasing your respiratory rate farther or increasing your tidal volume higher will do more damage than good. So this is where we check a blood gas. And here's the really important thing. You're not shooting for perfection. If you actually look at the ARMOR trial, so again, this was the trial where they actually showed that low tidal volume ventilation was better than standard tidal volume. The blood gases in the patients in the standard tidal volume group looked better. The patients just died more often. And so you're not shooting for perfection on your blood gas. What you really should be focusing on is delivering the appropriate tidal volume for the lung they have. It's okay if you're as long as you're in those requirements, that if your blood gas doesn't look perfect, so that your CO2 can be a little high or PO2 can be a little low. Trying to actually deliver a perfect blood gas usually does more harm than good for the patient. So this is what I'm saying. You're going to shoot for an O2 saturation on your pulse ox greater than 92% or a PaO2 greater than 60%, right? And that's all you need to do. You don't have to drive them up to normal PA2s or 100% sat. You're just going to titrate to those levels. And so you want to actually prevent hyperoxia and turning down your FiO2 to reach levels like this. If you're not getting ABGs all the time, you'd rather have an oxygen saturation that's not 100%. If your SAT's 98, 94, then at least you know your PaO2 is not 600. If your SAT is 100, you don't know if your PaO2 is 100 or your PaO2 is 600. It's hard to tell. So I try to shoot for a SAT of around 92 to 94, but greater than 92. And then our PCO2. Like I said, we want our PCO2 to be as normal as possible, but I'll tolerate elevated PCO2s if I can't achieve a normal PCO2 with a respiratory rate of 35 or less. And I will not up my tidal volumes to improve my PCO2. I'll keep those based on the expected lung volumes and then my plateau pressure. So kind of distill this down into a simple kind of graph here or an algorithm. You set your tidal volume, you shoot for 6 cc's per kg, somewhere between 4 and 450 cc's. Then you set your PEEP using the PEEP table, which we'll include in our kind of one-page document. Your respiratory rate goes from 18 to 35. You're shooting for a normal PCO2, but you can tolerate higher PCO2s if you can't get there. And finally, check your work. And the biggest thing here, the most important thing on this is your plateau pressure greater or less than 30. This is telling you that the tidal volume you're giving is likely not damaging that patient's lungs. And then we're shooting for an O2 SAT less than 92 and a PCO2 as normal as one can get it.
So Rory, just one question that just came in. Has anyone with these COVID suspected patients and COPD found that they are running into breath stacking with increased respiratory rates? Should we just tolerate hypercapnia?
Yeah, I mean, so I'm sure we don't know. This happens all the time on normal people with COPD that we intubate. Typically, though, once someone, even with COPD, gets ARDS, it's very hard for them to breath stack. ARDS is their lung compliance goes down and they have such small lungs and it's so tight, usually they exhale very fast. Like, so if you put any of us with normal lungs on a ventilator and tried to breathe them at 35, you would breath stack, all of us. But because these lungs get not stiff, I don't want to say that, because they're so small and the compliance is so poor, they exhale so quickly that it's pretty hard to breath stack someone in true ARDS. But yes, someone who has mild ARDS and has COPD, that's certainly someone you'd rather be concerned with. I would probably argue in the patients that has mild ARDS, you wouldn't have that much of a problem with your VQ mismatching, and you should be able to maintain a normal CO2 with a standard minute ventilation. if you can't maintain a normal standard minute ventilation because of breath stacking. So an easy example is asthma, right? Asthma lungs has normal VQ matching for the most part. And so with a minute ventilation of 5, you can usually maintain a normal CO2. The problem with asthma is you can't get a minute ventilation of 5 because you breath stack them at that normal respiratory rate. So yes, if you have someone who you can't even get a normal respiratory rate because of breath stacking, I would probably say it's more of a COPD/asthma picture than ARDS/COVID picture.
Great. Another question. If you intubate, what oxygen do you set the machine at initially percentage-wise? For instance, if on 6 liters nasal cannula and then you intubate, do you start at 40% or what would you recommend?
So, you intubate using optimal pre-oxygenation. You're shooting to get them as close to 100 as you can. You get the tube in. I always turn my FiO2 down to 40% immediately. And the reason I do this is twofold. One, when you leave it at 100% and check a blood gas and say you're going to come back later, nobody ever comes back later. And there's actually pretty good data on this, that the patient will sit on 100% FiO2 for 6 to 8 hours before anyone actually changes those numbers. So the first thing I like to do is make sure I have the appropriate FiO2 immediately, and I'll titrate using my oxygen saturation. The second reason is it gives me a decent idea of how much shunt physiology the patient actually has. When you're trying to titrate someone's PEEP and you're at 100% FiO2, it's really hard to know because people can stay at 100% FiO2 and de-recruit a lot of lungs and not see any changes in their oxygen saturation for a long time. And so I go down to 40%. And let's see, I'll start them on 5 of PEEP and 40%. And I see what their oxygen saturation does. If it starts to drop below 92%, I then increase my PEEP. And I increase my PEEP to, let's say, 8. And then I keep them at 40%. And that'll increase my PEEP to 10. And then I'll go up to 50% oxygen. And I'll start climbing back up that PEEP ladder. It's really hard to titrate your PEEP FiO2 ladder when you start at 100% oxygen because you don't know where your PEEP's going to be. So I start from the other side. The important thing to know is turning FiO2 up and down fast doesn't do anything really quickly to your lungs. If you drop your PEEP too quickly, you can de-recruit lung and you can get in trouble. But if you drop your oxygen saturation down quickly, your FiO2 will go down, but you can just turn it back up. And as long as you're standing at bedside, that shouldn't be too much of a problem.
That's great. Thank you.
Yeah. So just a couple other key considerations that's really important here. The first one is keep them dry. They have leaky lungs. Anyone in ARDS, and I'm assuming COVID's the same, have very leaky lungs, and a lot of fluid you give to them is going to spill out in their lungs, making their ARDS worse. We have pretty good data that the drier you keep these people, the better. We're working right now at Hospital Center, and I don't know system-wide, at kind of trying to exclude these patients from the normal CMS sepsis guidelines. Because we know a couple things. It seems like they present with straightforward ARDS and they don't have a lot of kind of sepsis and global shock. When they do develop shock, there is this concerning shock pattern of cardiogenic shock. And so our concept is we'd probably like to keep these patients on the drier side, so not bolusing them large amounts of fluid. And then I just thought about some rescue maneuvers. If you do get in trouble, this should work on most patients with ARDS. There's simple kind of algorithm that we go through. But important thing to note is patients don't like these respiratory settings. It's really hard for people to breathe on these low tidal volume settings. And we do a lot of fancy stuff in the ICU to get people more comfortable on them, but it can be pretty tricky. And so if you're getting in trouble and the patient is really non-compliant, they're fighting your vent, they're desaturating, they're double triggering, which means they take 2 inhalations for every breath, paralysis is an option. There was a recent trial, the ROSE trial, that looked at paralysis, globally for ARDS and found that it had no benefits. But the important part is even in the patients who didn't get paralysis, even in that group, about 15% of them ended up getting paralyzed because of non-compliance. So this is something that you can turn to if you're having a lot of trouble getting the patient compliant on the ventilator. And then proning. I normally think proning should not be done in the emergency department. I think if we're proning in the ED, we've got some problems with flow. But proning works really well for ARDS, and the data that's coming out is that these COVID patients respond really well to proning. And the concept of proning is you're actually just increasing the size of your baby lung. So your lung, essentially, when you're flying flat, looks like a triangle. You have two triangles side by side. The bottom is de-recruited, and the top is still open, participating in ventilation. When you turn that triangle upside down, the bottom now gets de-recruited, but it's a smaller area. So you end up re-recruiting lung. So essentially, the reason proning works is because you're expanding the size of your baby lung and decreasing the amount of strain on every lung unit. So, I mean, I think still that proning should ideally be done in the ICU. I think if we get into a lot of trouble and these patients are down in the ED for a while, proning is definitely something that we have to consider. This is going to require probably another WebEx and a whole lot of kind of nursing input and coming up with proning protocols. But what we're seeing out of this COVID group is they definitely benefit from proning. I would hope that we can get them up to the ICU before we can do it. And then call for help. This is important. Like, you know, there's patients that end up in what we call refractory hypoxemia, where you can't, these standard kind of PEEP titrations can't get their oxygen saturations up. So despite what you do, you're on 100% FiO2, you're on a pretty high PEEP, you're still not able to get them up to levels of oxygen saturation or PiO2s where you feel comfortable. There's other tricks we can do in the ICU, including APRV and different kind of recruitment maneuvers that come in handy. So I would say at this point, if you've kind of climbed your PEEP table and you still can't get them to respond, this is where you call for help and ask for someone to come down and kind of do some of these more advanced vent maneuvers. I think that sums it up for the presentation part of this. Happy to take questions.
It's great. We've had several questions come in, and really a fantastic presentation. And I think a helpful way of framing it, Rory, is you know, when we're looking at you know, our surge capacity and management of COVID as a you know, throughout the nation, throughout the world, there's kind of this dividing line between what we're seeing now and what we might see in terms of surge and having multiple patients. And I know there's several questions from the group, which I'll share in a moment, that really kind of get to that distinction between what we do tomorrow in the ED versus what we could potentially be exploring a couple of weeks down the road. So I just want to kind of throw that frame in there. If you wanted to expand on that at all.
Yeah, no, I mean, I think the big thing is we don't know. You know, ideally, if you look at these patients, they present with a viral ARDS pattern. They respond nice to PEEP. They decompensate fairly quickly pre-intubation. That's what we're seeing both out of China and Italy, is that, you know, they go from 6 liters of oxygen to requiring intubation between 6 and 8 hours, 6 and 12 hours. So they decompensate fairly quickly, but once on the ventilator, they actually respond fairly well to both PEEP and proning. And then there's this kind of later pattern where some of them will develop, even like they're recovering from their ARDS pattern, and they start developing this kind of refractory cardiogenic cardiomyopathy, which is concerning. But we don't know how many we're going to have, and so it is an interesting thing on what kind of resources we use. Right now at MedStar, or right now at Hospital Center, we're discussing, you know, early intubation for people that get on more than 6 to 10 liters of oxygen, because that seems to be what's working the best out of China and Italy. But, you know, if we start getting short on certain resources, that may become less and less possible.
No, absolutely. And just a couple of summary points. You know, first and foremost, protective lung strategies in terms of volume, lower volumes, a goal of around 6 cc's per kilogram of ideal body weight. And roughly, as you said, Rory, about 400 to 450 cc's for most adults.
Yeah, and the big thing there is check your work after. If you're kind of approximating in those tidal volumes, and as long as you're checking your plateau pressure and it's less than 30, you're probably doing okay. There's people with really bad ARDS or smaller people that once you put them on 400 and a plateau pressure is like 32, and that just means the tidal volume you're giving is too long for their lung size, so you turn it down at that point.
And then the other principle being the titration of PEEP in step with titrating up FiO2.
Yep. Because just think about your FiO2 requirement as the amount of shunt fraction you have. So the amount of lung that's de-recruited, or the higher oxygen requirement means the smaller the size of the baby lung. So there's more lung that might benefit from PEEP at that point.
Great. And then a couple of questions. And I know Dr. Shane Kapler has joined us as well. Shane, are you on the line?
Yeah, I am. Thanks, Judy.
Excellent, excellent. So Shane Kapler is our director of section of critical care for MedStar Emergency Physicians, and both Shane and Rory just wanted to get your input on NSAIDs. There's a lot that we're hearing about the use or lack thereof in the setting of COVID, and if you guys wanted to comment on that.
I'd probably add another controversy is around the ARBs and ACE inhibitors, and even some discussion about angiotensin II, in terms of its potential role in it. I mean, what I've seen the problem is I think a lot of this is a data-free zone, and so we're going off of basically a 3 to 4 week lead from our Italian and Chinese colleagues, and so from what I've seen is most people are recommending avoiding NSAIDs therapies, and there's not a ton of indications where you can't get away with doing some other alternative medication besides NSAID. So I think from what I've seen, and probably the safer path would be to avoid them. From the ARB-ACE standpoint, I mean, most of the large societies have come out saying not to stop those medications unless there's another reason to stop them. Or counsel patients not to stop them unless there's, a reason to stop them from a critical illness standpoint.
Yeah, so I mean, the bigger concept here is there's this thought that the COVID virus kind of binds to the ACE2 receptors in the lungs, and certain drugs that potentiate those receptors, meaning you have more of them, makes people more vulnerable. And the thought is that's why people with hypertension on ACEs or ARBs, or people with diabetes on glipizide, or people that take a lot of NSAIDs will have more of these receptors, making them more vulnerable to the disease process. We don't know much more than that. I think mostly in the ED in these sick patients, a moot point, you're not really going to be using any of these drugs. The question becomes more of a concern of someone who you're discharging and they're still on it, and maybe they have, they have a low suspicion for this kind of illness. Do you tell them to stop? I don't think we have a great data on that.
Great. And if it's okay with you both, I'd like to just transition. We do have a couple of additional questions I want to hold until the end, but I did want to cover some of the learnings from Dr. Du Bin, who is the MICU director at Peking University Hospital, and also president of the Chinese Society for Critical Care. And I believe several members of the surgical critical care team at the hospital center actually had a conference call, a teleconference call with him.
That's right. Shane, do you want to start, or do you want me to start?
You can take it.
So, I mean, the big things, there was a lot talked about. The big things, I think, especially for emergency physicians, is these patients present in kind of multiple ways, from asymptomatic to a fever and URI symptoms to this kind of respiratory distress syndrome where they start developing shortness of breath and hypoxia, to full ARDS. One of the interesting things to note is they can have apparently pretty severe hypoxia and look quite well. So they'll be sitting in front of you with minimal respiratory distress, but have SATs in the 70s and 80s. And those patients were at pretty high risk for decompensation. So that's something to really watch. And then the next thing to note is how quickly these patients decompensated. So going from minimal oxygen requirements to requiring intubation in less than a day. I think those were two of the big highlights for the management in the emergency department. And the last one is how well they responded to PEEP. They seem to really have recruitable lung and could respond to PEEP on the ventilator once you got them on.
I will also say there's a little bit of a controversy coming out around the use of steroids. The CDC originally said they were sort of against it, and that was more from our experience in previous coronavirus epidemics and critical illness. And from his point of view, he felt that there wasn't really a lot of benefit. But there's some new sort of data that came out. I think it was a JAMA article, right, Rory, today?
Yeah, it was JAMA today.
That was saying that there may be some benefit in this with COVID in sort of ARDS. So I think more to come on that, but recognize there's a big controversy that's sort of brewing around steroid use.
Yeah, the MedStar has got a group of us kind of working on like the early kind of treatment management recommendations. So that'll kind of get hashed out over and over again. I don't think that's something to worry too much about at this point.